Hello friends, this is Dr. Ganga, your nephrology educator at Prep Ladder. Today let us learn about Anti GBM disease, which is anti-glomerular basement membrane disease. So we'll study this topic under the following subheadings. First, we'll know the various terminologies that is required to understand this chapter. Then we learn about type 4 collagen, what is the etiology and pathogenesis of this disease, what are the predisposing events, clinical features, differential diagnosis, natural history, treatment. Then we'll go into the KDIGO guidelines as to what treatment they are suggesting. Then we'll just have a glimpse into what is RPGN, that is rapidly progressive glomerulonephritis. And then we'll have a quick revision. This quick revision is just like a 2-minute capsule for you to come back if you are quickly revising or preparing just before the exam. So in these sections, I would have stressed upon the topics that have been asked in exams. Okay. So first, let us learn the terminologies that is associated with the diseases involving the lung and the kidney. Okay. So first is pulmonary renal syndrome. See, pulmonary renal syndrome is any non-immune cause of lung and kidney involvement. It might be because of some infection. It can be because of pulmonary edema, because of cardiogenic causes. So in all these causes, both lung and kidney will be involved, like cardiorenal syndrome. But in this, what happens? It doesn't mean that there are antibodies produced. Okay, so it is non-immune. The rest of the things are immune. So first, let us come to what is called as Goodpasture syndrome. So you know, once the word syndrome comes, it means it is a broad or a huge terminology under which subheadings will be there. So Goodpasture syndrome is any condition in which there is rapidly progressive glomerulonephritis and alveolar hemorrhage. That is RPGN plus there is blood in the alveolus. Okay, alveolar hemorrhage. So this is called as Goodpasture syndrome. This has several causes, like if it is involving only the anti-GBM, then it will be called as Anti GBM disease. Now this can be because of some vasculitis. So multiple causes are there. We'll come to it. Okay, so Goodpasture syndrome is any cause which can cause rapidly progressive glomerulonephritis with alveolar hemorrhage. Okay. Next, coming to Anti GBM disease. So this Anti GBM disease is a part of Goodpasture syndrome. Okay, Goodpasture syndrome, Anti GBM disease is a part of it. Now, what is Anti GBM disease? That means there are antibodies against the glomerular basement membrane. It can be against any component. For example, if it is against the alpha-3 component of the collagen type 4 of the glomerular basement membrane, we'll call it Goodpasture's disease. Or if it is against alpha-5, then we call it post-transplant anti-GBM disease, which is seen in condition like Alport syndrome. Because we know in Alport syndrome, the alpha-5 gene is mutated, right? So once this patient gets a new kidney, what happens? The new kidney, the donor's kidney will have normal alpha-5. So the body which is getting exposed to this normal alpha-5 is going to produce antibodies against this alpha-5. So this will go and bind to the alpha-5 in the GBM and cause an anti-GBM disease. However, this is not Goodpasture's disease. Okay, that is something we have to remember. So anti-GBM disease just means there are antibodies against the GBM. So it can be against alpha-3, which is Goodpasture's disease, which we are going to see in detail, or it can be against alpha-5. So this much you understood. Now, there is a part of anti-GBM disease. There are two parts of anti-GBM disease. The first one is Goodpasture disease. Second one is Alport syndrome post-transplant anti-GBM disease. Now, Goodpasture disease is disease with autoantibodies directed against alpha-3, okay, of type 4 collagen. This may include RPGN, lung hemorrhage, or both. And it happens because of autoimmunity to alpha-3, like I explained. Alport syndrome post-transplant anti-GBM disease, that is in a patient who has achieved ESRD because of Alport syndrome. When you do post-transplant, when you see post-transplant, they develop anti-GBM disease. Okay. So this is glomerulonephritis associated with anti-GBM antibodies developing after renal transplantation in patients with Alport syndrome. This is like how I explained here. Now, there is immunity to foreign collagen 4 chains which is not expressed in the patients with Alport syndrome. Okay, that's what I told here. So, generally, alpha 5 is not expressed in these patients. So, because that is not expressed, when a normal donor kidney with a normal alpha 5 comes to the recipient's body, it's something new for the patient. So, they are going to generate antibodies against it. So, you understood pulmonary renal syndrome, which is a non-immune entity. It can be anything like an infection. It can be anything like a cardiorenal syndrome, which is involving both lung and the kidney. Second is Goodpasture syndrome. This is a huge terminology causing anything that causes both rapidly progressive glomerulonephritis and alveolar hemorrhage. So, it can be because of antibodies against the GBM, or it can be because of systemic process like vasculitis. Now, third step is we are coming to Anti GBM disease. That is, there can be antibodies against the alpha 3 of the GBM or against alpha 5. Now, we are coming to the subsections of Anti GBM. That is, first is Goodpasture disease. That is, if there are antibodies against the alpha 3. Okay, that we'll learn it in detail now. Second is coming to Alport's disease post-transplant Anti GBM. In this, there are antibodies against the alpha 5. Okay. So, these are the important terminology. So, later when we are referring to this, you shouldn't get confused. Now, coming to the etiology and pathogenesis. So, before going to this, I will just show the normal type 4 collagen chain. So, this is the type 4 collagen structure. Type 4 collagen is present in almost all basement membranes everywhere in the body. But the type of the alpha chain which forms this type 4 collagen varies in each structure. For example, this type 4 collagen is formed from alpha chains which are alpha 1, 2, 3, 4, 5 and 6. Okay. So, majority everywhere in all basement membranes, it is this alpha 1 and the alpha 2 which is forming network. That is, generally it's going to be triplet. So, it will be 2 alpha 1 and 1 alpha 2. Okay. Similarly, you can see alpha 5, alpha 6 forming network. Now, when coming to the glomerular basement membrane, it is alpha 3, alpha 4, alpha 5 which is forming the network. So, here you can see these three things are tightly wound around and they form the network in type 4 collagen. Now, this is not just in GBM. It can also be found in the alveolar basement membrane. It can be found in the cochlea. It's also found sometimes in the cornea. Okay. So, cornea, cochlea, alveolar basement membrane and kidney. So, that is why there is alveolar involvement in Anti GBM disease because of this type of alpha chain that is there in the type 4 collagen. Okay. Now, coming back to this slide. So, there is autoimmunity to a component of the glomerular basement membrane. The autoimmunity is to the carboxyl terminal of the NC1 domain of the type 4 collagen of alpha 3 chain. Okay. So, when you come to this picture, see, this is the alpha 3. So, here is the carboxyl terminal and the NC1 domain. So, it's simple. The NC1 domain, carboxyl terminal, alpha 3 chain of the type 4 collagen. So, it is simple. So, this is called as Goodpasture antigen. Okay. So, this is what is the Goodpasture antigen against which the antibodies are produced. So, it is simple. Understood which is the antigen against which antibody is produced. Now, what are the predisposing factors that will lead to development of these antibodies? Okay. So, genetic factors are there, precipitating factors are there. Genetic is its association against HLA class 2 alleles, DRB1 star 1501 and DR4. These are considered as high risk alleles. Protection is DR1 and DR7. Okay, generally, I tend to remember the protective genes and anything that is not that, I consider that as high risk when it comes as MCQ. For example, see if the question is framed, they will ask which is a protective allele. That is the most common possibility, or it might come as an option like which of the following is false. They can ask DR4 is a protective allele. So, 1 and 7, if you can remember, 1 and 7, these are protective alleles. So in the question, if anything else comes, you can rule it out by exclusion. That is pretty simple. Okay. So the precipitating factors. The precipitating factors means anything that exposes this glomerular basement membrane. There's a glomerular basement membrane or there is a alveolar basement membrane. Okay. So this anything that exposes this alpha 3 chain, that is the NC1 domain of the carboxyl terminal of the glomerular basement membrane or the alveolar basement membrane, can precipitate this disease in a person who is at high risk of having anti GBM. That can be for the lungs, it can be hydrocarbon exposure, it can be cigarette smoking. In the kidney, it can be any trauma or inflammation, something like a vasculitis, okay, which is going and causing necrosis in the GBM and exposing things. Or it can be membranous nephropathy, which you very well know. It leaves the spike pattern, it leaves the whole pattern in the GBM, it exposes the GBM because the antigen antibody which gets deposited has to get cleared, right? So it exposes the GBM in membranous nephropathy, similar in small vessel vasculitis. So basic concept is anything which exposes the collagen of the glomerular basement membrane or the alveolar basement membrane. Okay, so these are the predisposing events associated with presentation of Goodpasture disease. Possibly this induce autoimmune response and hence cause the disease. So it can be a small vessel vasculitis which is affecting the glomeruli, like I already told, membranous nephropathy, or it can be renal trauma like lithotripsy of the renal stones, or urinary obstruction, okay, and alemtuzumab therapy for MS. So this can be because of the antibody deposition and causing glomerular damage, exposing the alpha 3. So these are all the immune causes. So you know vasculitis, you know membranous nephropathy, then renal trauma or inflammation like in lithotripsy, urinary tract obstruction, or antibody, that is alemtuzumab therapy. Second is things that can precipitate pulmonary hemorrhage. So these are the things that are toxic to the lungs, like it can be cigarette smoke, or it can be hydrocarbon exposure, or any infection to the lung or fluid overload. So all these conditions inflame the alveolus and it can expose the antigen and it can cause the disease. Okay, so this is important. Like you can see that patients who generally present with alveolar hemorrhage are smokers, or they would have had some sort of hydrocarbon exposure. So in the question, for example, you get a patient, like for example, a 25-year-old male presenting as crescentic glomerulonephritis with breathing difficulty, history of smoking, then your diagnosis should be anti GBM disease. Okay. Now, we know that the antigen is exposed. How does it cause renal injury? Once the antigen is exposed, there is formation of antibodies. Okay, that is alpha 3 of collagen 4, NC1 domain autoantibodies. These autoantibodies are IgG1 type. Okay, and renal injury happens once these antibodies are deposited. We of course know that it is going to stimulate the complement pathway. Complements are going to get deposited, and as scavengers, as destroyers, neutrophils and macrophages are going to come. Lung hemorrhage happens only if additional insult happens, like there is some fluid overload, or patient has any infection, or if patient has some coagulopathy leading to bleeding into the lungs, or if patient is going to have smoking or hydrocarbon exposure. Okay. Generally, why this happens is because these antibodies have very good access to GBM more than the alveolar basement membrane. So we know that the glomerular basement membrane has lot of fenestrations, a whole lot of capillaries. So lot of antibodies can come, lot of neutrophils and macrophages can come. So that is why the intensity with which the GBM, the glomerular basement membrane, is affected, the alveolar basement membrane is not affected. Okay. Now, generally, we see male preponderance in this. Lung hemorrhage is seen in younger patients. So these are the patients who are prone for more smoking or occupation-related hydrocarbon exposure. So it is more common in them. And generally, bimodal is the presentation is bimodal. Once it can present in third decade or it can present in sixth decade. Okay. So bimodal presentation of Anti GBM disease. This you have to remember. Now, coming to the clinical features. So, two important organ involvement is one is lung and one is the kidney. So, 50 to 75% of patients present as lung hemorrhage and advanced renal failure. Okay, so renal failure is going to be pretty advanced. Now, these can present abruptly, sudden onset, or they can present over weeks to months. Okay. Now, coming in detail about lung hemorrhage, it can occur with renal disease or it can happen in isolation, that is just with lung hemorrhage. Patient can present with cough with or without hemoptysis. So if the blood is not coming out, that means it will get collected inside and it will cause exertional dyspnea. So how to diagnose this? X-ray, once we do X-ray in these patients, like all CKD patients are going to complain of dyspnea, or all patients with renal failure are going to complain of dyspnea. So how do we differentiate? X-ray, it becomes difficult to differentiate between edema and infection. Most sensitive is increased uptake of inhaled carbon monoxide. So because there's a lot of blood, there's going to be increased uptake of carbon monoxide. So this is the most sensitive technique to detect alveolar hemorrhage. This has been asked as a question multiple times. So you have to remember that for lungs, we use DLCO, that is increased carbon monoxide uptake. Okay, it is not decreased, it is increased uptake because blood is there. There is going to be increased uptake of carbon monoxide. That has also been asked, that whether there will be decreased uptake or increased uptake. So this you have to remember, it's very important. Restarting. Now coming to the glomerulonephritis. Now we just finished lung hemorrhage. Coming to glomerulonephritis. Patient can have dark or red urine like any glomerular hematuria. They can present with oliguria. 30 to 50% present isolated kidney involvement, okay, without any lung hemorrhage. And urine routine will show hematuria, RBC cast and modest proteinuria. So this is like any other glomerular disease. So you have to know they can present as isolated lung involvement, isolated kidney involvement, but majority, that is 50 to 75% present as combined. Okay. Now pathology. So this is the picture of the glomerulus. You can see there is diffuse proliferative GN. That is, here is the glomerular capillaries. If you see, there is so much proliferation inside. These are the cells. Okay. And also there can be glomerular capillary thrombosis. Okay. So once it is thrombosed, what is going to happen? That part of the glomerulus is going to die. There's going to be necrosis. And there is going to be crescents, like you can see in this picture, this beautiful crescent. So that is extra capillary. Okay, that is podocyte are going to proliferate and lead to crescent formation. So this is the crescents that you can see. Okay, and there's going to be tubular atrophy. The most important thing about this is crescents are similar age and cellularity. Okay, so what happens? A lot of anti-GBM antibodies are produced at a time. It's going and hitting the kidney at the same time. So all glomerulus are going to get affected at the same time, causing similar age crescents. This is important because the same picture, the same light microscopy picture, you're also going to see in vasculitis. I'll talk about this in detail when I'm talking about when I teach vasculitis. So in this also, there are going to be plenty crescents. Okay, but how do we differentiate? Is crescents are going to be of different age because vasculitis is a continuous process. It's not like antibodies produced in one surge and then it stops. This is a continuous process. So crescents keep occurring at different ages. Okay. So here in anti-GBM, you have to remember that all crescents are of same age. Now, coming to the immunofluorescence, which is very, very important. Here you can see this beautiful deposition of the immunoglobulin. So this immunoglobulin will become positive when it is stained for IgG1. Okay. So it is deposited along the glomerular basement membrane. This is pathognomic of anti GBM disease. Okay. Mostly it is IgG 85 to 90%. Rarely you can find IgA or IgM 10 to 15%. There is linear deposition of C3 in 75%. So along with IgG, here you are going to find C3 deposits. Okay. So it is not just in anti-GBM disease. In other diseases also there is binding of IgG to the glomerular basement membrane. But this is non-specific binding. I'll tell which are those conditions. What happens is, in this, when there is non-specific binding of IgG, how do we differentiate it from anti-GBM diseases? There's going to be less abundant immunoglobulin, and they're going to be non-specifically deposited, and they're not going to be bound to type 4 collagen chains. Okay, so they're less abundant and they're not going to be specifically bound to type 4 collagen. So which are the conditions in which there can be non-specific binding to anti-GBM? Okay, non-specific binding to GBM. First is, we know specific binding to GBM is Goodpasture syndrome or Alport syndrome after renal transplantation. Okay, so that means both causes of anti-GBM disease. So this is like a quick revision for you that anti-GBM disease is these two things. Okay. Now, non-specific binding can be seen in diabetes, it can be seen in cadavers, light chain disease and fibrillary glomerulopathy. This is very important. It has been asked as a question multiple times. These 4 options can be asked. So, if you see their biopsy, it's going to show same pattern. This IgG deposits in the GBM, but it will not show other light microscopic changes. So, that's how we differentiate. Okay. So, it is going to be in diabetes, it can be in cadavers, it can be light chain deposition diseases, or in fibrillary glomerulopathy. Okay, so these 3 diseases, it's by disease per se. This is because cadaver kidney, because there is trapping of these antibodies, so it will be there. Okay, so this is one important thing for you to remember. Now, which are the other investigations? Apart from renal biopsy, we can do the circulating anti-GBM levels, IgG anti-GBM levels, and this titer, if the titer correlates with the severity of nephritis, that is, higher the titer, more severe is the disease. Okay, this titer also helps us in knowing the treatment effectiveness. That is, we have to do plasma exchange till the titers are negative. Okay, so that will be our goal for plasma exchange, and it also helps us in predicting the relapse. Though relapse is very, very rare, it will help us in predicting the relapse. Okay, now what happens to pathology in other tissue? Lung is always patchy involvement. Okay, so some part of alveolus might be involved, some part might be uninvolved. So what is going to happen is, it can be missed. If you do a biopsy, it can be missed. So that's why kidney biopsy is not, you must be thinking, oh, why you're doing only kidney biopsy, why we can't do lung biopsy, even lung is accessible. So this is the reason, it's going to be patchy and it will be missed. Okay. Now other is in placental tissue. Placental tissue is like a sink. Okay. So all antibodies are going to come and deposit there. So even in placental tissue, we can find antibodies, but of course no one is going to do biopsy of the placenta. But the significance of this is, once the lady delivers, once the placenta gets out of the body, all these antibodies will not have a sink, and it's going to go bind to kidney tissue, and it's going to precipitate anti-GBM disease. Okay, so these are the other tissues in which you can find anti-GBM antibodies. Now coming to the differential diagnosis. Differential diagnosis, we can rule out. One is by direct immunohistology of the GBM. This is by doing renal biopsy, where you find the anti-GBM antibodies along with the light microscopic findings. Second is antibodies in the serum. You can detect. It can be false positive in some inflammatory diseases, which can elicit antibodies to the glomerular basement membrane, like in vasculitis, you assume. This can come positive. Okay. It can be false negative. That is, anti-GBM disease can be there, but still it can be negative when there is isolated lung involvement, where that it's very small amount of antibody, so it's going to go deposit in the lung. You're not able to find it anywhere else. Or in very early renal disease, again, when all antibodies are going and sitting in the kidney. Or after renal transplantation, Alport syndrome, because we know here the antibody is against the alpha 5. So if you're going to check against alpha 3, you're not going to find anything. So 3 conditions in which the antibody testing can be false negative. That is, even if it is there, you won't get. That is when there is isolated lung involvement, or early renal disease, when the antibodies are so low, it will go all deposit or in early renal disease when antibodies are so low it will go deposit in the kidney, or third is after renal transplantation for Alport syndrome, where you have to search for alpha 5 and not alpha 3. Now, patients with anti GBM and other diseases. Okay, so there is an important condition called double positive disease when patient has both anti GBM and ANCA. Okay, so this has been asked as a question multiple times. Okay, so here ANCA will be specific for only MPO, that is not PR3 ANCA. It will be specific for MPO ANCA. Okay, so the antibodies that are produced in the vasculitis are going to damage the GBM, and this is going to expose the alpha 3 and going to lead to antibody production, which will cause vasculitic glomerular damage. Okay, and the course and response is similar to vasculitis in this condition. Whatever response to the disease is similar to vasculitis. Okay, the other condition is membranous nephropathy and alemtuzumab therapy. So that is not very important. You have to remember this double positive disease or dual positive disease. Okay, you have to remember that the response is similar to vasculitis and not similar to anti GBM. So this is the pulmonary renal syndrome that we discussed in the first slide. So we know it can be because of autoimmune causes and non-autoimmune causes. So non-autoimmune causes mainly causing pulmonary renal syndrome are, if it's with pulmonary edema, it can be AKI with hypervolemia, severe cardiac failure, or infective, which can be bacterial, which can be viral, or opportunistic infection, or it can be other, like ARDS with renal failure in multi-organ failure, paraquat poisoning, or pulmonary embolus with some renal vein or inferior vena cava thrombosis. So these are all the non-immune causes. There are many causes non-immune. Now important is immune causes. So once you come to the immune causes, you call it Goodpasture syndrome. Okay, so this is RPGN plus alveolar hemorrhage. Okay. Okay, so under that we know if there are antibodies to the GBM, it becomes Goodpasture disease. Disease associated with systemic vasculitis, like it can be vaginous, it can be microscopic polyangiitis, SLE, Churg-Strauss syndrome, IgA vasculitis, HSP, Behçet's, cryoglobulinemia, rheumatoid, and drugs which can cause vasculitis like penicillamine, hydrolysine, and propylthiouracil. So these are basically the causes whichever can cause vasculitis. Okay, you don't have to worry. Whichever disease can cause vasculitis can precipitate Goodpasture syndrome. Okay, involving alveolar hemorrhage and RPGN. Now, natural history. The lung hemorrhage and advanced renal failure generally happens over weeks to months. Or it can present as RPGN also, which I told, rapid, and where there is rapid and irreversible loss of renal function. More glomerulus are simultaneously affected. Like I told, it is all crescents are going to be of same age. Lung hemorrhage generally responds fully to treatment and recovers. That's very important because kidney, that is not going to happen generally. Lung hemorrhage generally fully recovers, but it can be relapsing and remitting. Okay, lung hemorrhage fully recovers, but it can be relapsing or remitting. So 3 years. Okay, fully recovers, but it can be relapsing and remitting. Okay. Now, cause of death early on, it can be because of lung hemorrhage when it is severe, or late it can be because of infection. So now coming to the treatment. So immunosuppressive regimens are not given to all patients. It is given to patients who are having lung hemorrhage. Okay, so dialysis dependent patient, generally there is no use treating them with immunosuppression. That's a very important point that has been asked multiple times. In a dialysis dependent patient, only if lung hemorrhage is there, then you will give immunosuppression. This is because if the patient is dialysis dependent, that means the presence are extensive, the disease is extensive. Okay, so even if you treat, there's not going to be much point. Second is, if immunosuppressive regimens can reduce the levels of circulating antibodies immediately. For example, there's severe lung hemorrhage. You want to reduce the level of circulating antibody immediately. Then you can proceed with that. Then after disease control occurs, taper off in 3 months. Generally by 6 months, the whole course of immunosuppression will be over. Okay. And generally, even if there is no treatment, the antibodies will disappear over 1 to 2 years. Even if you don't treat and patient goes into complete renal failure, these antibodies will not stay permanently. It will disappear over 1 to 2 years. Relapse is uncommon in kidney disease, and treatment has to be started even before biopsy report comes, because biopsy report might take 1 to 2 days. Do not wait until then. If your suspicion is strong, start with plasmapheresis. Okay. So that is the thing. The important thing to remember in this page is that in dialysis dependent patients, we do not do aggressive immunosuppression unless they have lung hemorrhage. Okay. So plasma exchange and immunosuppression, like I told, in moderately severe disease, but not dialysis dependent or severe disease, and when lung hemorrhage occurs. Now, this is a very, very important table. Okay, factors in decision to treat good pasture disease aggressively. So first you see the factors in which you don't treat aggressively, then this will become easy. The condition in which you don't treat aggressively is when creat is more than 5.5 to 6.5. So once the patient's creatinine is more than 5.5, you are not going to give immunosuppression. The only exception to this is if the patient is ANCA positive, that is the double positive disease, like we told, where the patient will be treated like ANCA vasculitis. Second is when there is lung hemorrhage. Okay, so these two conditions are absolute indications to go for plasmapheresis and immunosuppression even if creatinine is more than 5.5. There are other indications like there is rapid and recent progression, that is suddenly patient comes, ANCA is positive, glomerular damage is less severe, that is the crescents are not there in all glomeruli, it's very less, and they are recent crescents. So we know crescents can be fibrinous or crescents can be cellular, or it can be in between. So if the crescents are cellular, that is, you know that they are recent and they're going to respond to therapy, then you can consider immunosuppression. And if early renal transplantation is decided to clear out the antibodies. Okay. So basically, if creatinine is more than 5.5 to 6.5, you will attend only if there is lung hemorrhage or if ANCA is positive. And other indications are if glomerular involvement is less severe than you're expecting, or if crescents are not 100%, in these conditions you can try. Okay. So again, here you see if pulmonary hemorrhage is present, then you are going to immunosuppress. Similarly, oliguria should be absent. Creatinine should be less than 5.5. We discussed this table. So this is very, very important table. Now, supportive treatment, you have to give supportive treatment. Avoid precipitating lung hemorrhage. Okay. So lung hemorrhage can be precipitated in these conditions. If there's fluid overload, if there is smoking or other respiratory irritants, if you're giving NIV or ventilating with high FiO2, if there is some infection, or you give anticoagulation which will cause lung bleeding, or there is depletion of clotting factors because of plex. So same thing, volume overload or infection or respiratory irritants or anticoagulation in the body, all these things can precipitate lung hemorrhage. Okay. So how do you monitor treatment? First is the renal disease, we see serum creatinine improvement in urine output. Lung, we can monitor hemoglobin drop, because if hemorrhage is there, there will be hemoglobin drop. We can see the chest X-ray. Most important thing is DLCO. Okay, so if there is increased carbon monoxide absorption, okay, increased absorption with carbon monoxide, then it is considered as a sensitive test. Okay, it's more sensitive. And anti GBM antibodies. Generally, we continue plasmapheresis till anti GBM antibodies become negatives. And it completely goes off from the body by 8 weeks of treatment. Sometimes till 14 months it can persist. Okay, this is in patients in whom treatment has not responded. Generally by 2 months it is going to completely clear out of the body, but it can last till 14 months. Okay. Now duration of treatment and relapses. 3 months is the treatment for cyclophosphamide, 6 months of steroid. In double positive disease, it requires longer time of treatment like vasculitis. So when coming to vasculitis, we learn about it. Relapse is very rare. Okay, so we need not worry about relapse in anti GBM disease. Double positive disease, like I said, this is very important. It is prognosis is better than just anti GBM alone, because we know that if it's a severe disease, then anti GBM immunosuppression is not going to work. But vasculitis is one condition, even in severe disease, immunosuppression works. So if you see the prognosis, double positive disease has better prognosis than anti GBM. This also has been asked as a question multiple times. Okay. And this condition requires prolonged treatment, unlike in anti GBM disease, which only requires 3 to 6 months of therapy. Now, transplantation. Transplantation will be done after the anti GBM antibodies are undetectable in the body for 6 months. Okay, so that is very important. The one that happens with Alport syndrome, that is Alport syndrome post-transplantation anti GBM disease, it's mutation of alpha 5. 2% of patients develop this and develop graft loss. Okay, and the duration varies. It can happen over subsequent transplant. That is, first transplant it might take few months. The next transplant it might be shorter. The next transplant it might be even shorter. So subsequent transplant the duration will vary. And we have to check for anti-alpha 5 antibodies, not anti-alpha 3 antibodies. Now, what does KDIGO guidelines tell? This is because now a lot of questions are being asked from KDIGO guideline also, and it's very intimidating to open that and read. So once you listen to this section, if you just quickly flip through, you will be able to understand better. I've included almost everything that is important from KDIGO guidelines. So even if you don't get time to read it, it's okay, it's fine. Okay. So you treat all patients of renal failure except the ones requiring dialysis, like we discussed, or 100% crescents on biopsy, or more than 50% glomerular sclerosis. Okay, so the dialysis requiring, in that we read it was more than 5.5 to 6.5 creatinine, or crescents are 100%, or if it is glomerular sclerosis, more than 50%, that means it's a chronic disease. However, pulmonary hemorrhage has to be treated. Now, start treatment even before diagnosis confirmed. We discussed this. Plasma exchange should be continued till all the anti-GBM antibody titers are negative. Cyclophosphamide can be given for 3 months and steroid for 6 months. No maintenance therapy is required like in SLE and vasculitis. Double positive disease should be treated like ANCA vasculitis. So all this is just a revision for you. In refractory cases, rituximab can be tried. Kidney transplant to be done after 6 months of negative titers of antibody. Okay. Now this is the treatment. Plasma exchange, the dose is 40 to 50 ml per kg. Till when will you do? Till the circulating anti-GBM antibodies can no longer be detected. Generally, it is 2 weeks time. Cyclophosphamide, you give oral 2 to 3 mg per kg. Generally, the treatment duration is 3 months. And steroids, generally you start with pulse steroid. You give 1 gram for 3 consecutive days and continue 1 mg per kg. After 6 weeks, that is around 1.5 months, you are going to taper the dose to 20 milligram by that time. Okay. And total duration of treatment is 6 months. So, cyclophosphamide, plasmapheresis and steroid. These 3 are going to be the main treatment in anti-GBM disease. Okay. Now, just a small glimpse of what is rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis is when glomerular injury occurs, which is acute and severe. Okay. So that renal function deterioration happens over days to weeks. Now you might ask, how is it different from AKI? So AKI we know generally 7 days. So when a patient presents with AKI, patient can present because of glomerular involvement, which is called RPGN, or it can be because of interstitial involvement. It can be because of tubular involvement. So interstitial involvement is something like AIN, right? And tubular involvement is something like ATN, or it can be because of vascular involvement, like something like a TMA or renal vein thrombosis. So RPGN is a subsection of AKI. RPGN you call it when over days to weeks, the kidney function has deteriorated. Okay. Histological counterpart is crescentic GN. So when a patient has RPGN, generally when you biopsy, you are going to find crescents. And there is acute deterioration of renal function with crescents. So that is the meaning. So these are the conditions that can present as RPGN. So first is we read anti GBM disease, that is Goodpasture syndrome. Second is vasculitis. See, don't worry about this table. Whenever you read that chapter, it will become very easy for you. This is just the names. Okay. So again, this is ANCA vasculitis. It can cause crescents and RPGN. Then immune complex disease like SLE, post-streptococcal glomerulonephritis, infective endocarditis, and IgA nephropathy causing IgA vasculitis. Okay, so in all these conditions, there can be crescents. So in good pasture disease, you are going to see anti GBM antibody and biopsy will show presence of similar age. Similarly, vasculitis biopsy will help us in diagnosis and presence of C ANCA, P ANCA. Okay. And here you can see microscopic polyangiitis will show multi-system involvement. You will find P ANCA. Pauci-immune crescentic gene, that is only kidney involvement of vasculitis, will show P ANCA. Okay. Now, other immune complexes diseases like SLE, post-streptococcal glomerulonephritis. So in SLE, you are going to find ANA positivity. Both complements C3 and C4 are going to be low. Similarly, in PSGN, you are going to find C3 is going to be low and ASO titers can be high. In IgA nephropathy, you are going to be serum Ig can be high, C3, C4 are normal. There is going to be generally biopsy diagnosis. Similarly, endocarditis, you're going to find a new cardiac murmur, and blood cultures generally will come positive. Sometimes ANCA can be positive, C3 will be reduced, C4 is normal. So all these in detail you will learn about that particular disease. Just remember, it can happen because of anti GBM disease, it can happen because of vasculitis or immune complex deposition like SLE or some infection. That is IRGN or PSGN or in endocarditis, or it can also occur in IgA nephropathy. So these are all the causes of RPGN. If RPGN patient comes, what you're going to do is first you check if alveolar hemorrhage is there or not there. If alveolar hemorrhage is not there and you're suspecting anti-GBM, generally we don't immunosuppress. In other conditions, we can immunosuppress. Okay. But if biopsy is showing 85 to 100% of crescents, then there is no point in generally immunosuppressing the patient. If alveolar hemorrhage is present, then you send anti-GBM antibodies, ANCA, ANA, exclude the infection because all these cause of RPGN you will try to exclude. Now, if the data is not back within 24 hours, you start with plasma exchange and glucocorticoids. Okay, that is the thing. If data is back within 24 hours that it is anti-GBM, you add cyclophosphamide. And then you monitor kidney function. That's the only thing. So basically, when a patient presents with with RPGN, do not waste time. Okay, immediately, if you can biopsy or not, it's okay. Get a CT, see if there's alveolar hemorrhage, and then send your anti-GBM workup. Try to do a biopsy. And if you know that the report doesn't come within 24 hours, immediately pulse the patient with methylprednisolone, start the patient on plasmapheresis. By the time if the report comes back as anti-GBM, add cyclophosphamide. Or if report comes as vasculitis, there are specific treatment. If report comes as SLE, there are specific treatment. So it is like that. Okay. Between you have to rule out the infection. Okay. Don't immunosuppress the patient heavily when they have some underlying infection like endocarditis or something. If there is no alveolar hemorrhage, then and if biopsy shows some 100% crescents and all, then there is no much point immunosuppressing, especially in anti GBM disease. Now, let's come to the most important section of this topic. Okay, we'll do quick revision. Whenever you have less time, come back to this section. Okay. Now, first is good pasture syndrome versus good pasture disease. We know that good pasture syndrome consists of any cause that can cause RPGN plus alveolar hemorrhage, which can be anti GBM disease or which can be some vasculitis that is causing. Whereas good pasture disease is when there is antibody that is directed against the alpha 3 chain, okay, alpha 3 chain of the collagen type 4, that to the NC1 domain. Quick revision. Pulmonary renal syndrome, mostly non-immune causes. The immune causes will be called as generally good pasture disease, right? Good pasture disease, you know, when there is RPGN with alveolar hemorrhage. Then there is anti GBM. Anti GBM basically consists two things. One is good pasture. This is good pasture syndrome. I just missed it. So good pasture syndrome is when there is RPGN with alveolar hemorrhage. Then there's anti GBM disease, which has two important components. One is good pasture disease. Another one is the Alport syndrome post-transplant anti GBM disease. So this is against the alpha 3. This is against alpha 5. Okay. So good pasture antigen is nothing but the NC1 domain of the carboxyl terminal of NC1 domain of the carboxyl terminal of the alpha 3 chain of the type 4 collagen. The most sensitive technique to identify alveolar hemorrhage is increased diffusion of carbon monoxide, increased DLC. Precipitants of alveolar hemorrhage, we know it can be smoking, it can be hydrocarbon exposure, it can be fluid overload, or it can be infection. Okay, so these can be the precipitants. Now, conditions causing non-specific binding to anti-GBM, binding to GBM. Okay, so the immunofluorescence will appear similar to anti GBM disease. So this can be diabetes mellitus, it can be cadaveric kidney, it can be light chain deposition disease, or it can be fibrillary GN. Okay, so these are the 4 things that you have to remember. Double positive disease. So this is when ANCA is positive along with anti GBM. Generally, ANCA is the primary disease which is exposing the GBM, which again develops anti GBM disease and causes the condition. So generally, the ANCA that we see is MPO ANCA. Okay, and here you have to treat it like vasculitis. The treatment and prognosis is like vasculitis. Okay, prognosis is better in double positive when compared to anti GBM. Okay, so this is with respect to the double positive disease. Now, factors against the aggressive treatment, that is if creatinine is more than 5.5 to 6.5 or dialysis requiring disease. The exception to this is if the patient has lung hemorrhage or if renal biopsy shows less severe kidney disease, that there is no 100% crescents, or if patient requires early transplantation. So in these conditions, you are going to go ahead and consider immunosuppression. Transplantation generally should be done after 6 months of negative anti-GBM antibodies. Okay. So thank you friends. I hope I have helped you in understanding this condition. It's very, very important from your exam point of view. Thank you.